Today, I'm lucky enough to have a pediatric ophthalmologist with me, Dr. Golareh Fazilat. Hi, Dr. Fazilat. Thank you for being here.
Hi, thank you for having me here.
I'd like to start with some background about you because this show is really based on finding very well respected and well learned specialists. So, let me give a little background and then we'll go into our first topic about amblyopia.
Sure.
So, Dr. Fazilat is the director of the Children's Eye Center of Orange County and is board certified as an ophthalmologist with an expertise in strabismus and pediatric ocular disorders. She completed her ophthalmology residency at the George Washington University in Washington, D.C. Subsequently, she completed her fellowship in pediatric ophthalmology amongst a selective elite group of residents at the USC Children's Hospital, Los Angeles. Dr. Fazilat was recruited to serve as an assistant professor of clinical ophthalmology at the Vision Center of Children's Hospital LA and the University of Southern California Keck School of Medicine. She has spent many years teaching clinical and surgical skills to ophthalmology residents and pediatric ophthalmology fellows. As an expert in her field, Dr. Fazilat is regularly invited to present at national and international conferences. In addition, she volunteers her time and expertise by offering medical and surgical care to patients in developing countries where access to medical care is scarce. She's an active member of multiple medical societies, including the American Association for Pediatric Ophthalmology and Strabismus and the American Academy of Ophthalmology. Her philosophy is to work closely with other ophthalmologists, pediatricians, family physicians, and optometrists to provide the most comprehensive care for each patient. For this, I can attest is true because you're always a phone call or a text away. Her technical skills in ocular surgery, along with her devoted approach to children as a whole, have helped to improve the quality of life of numerous patients with ocular disease. There's
Thank you.
There's no better summary, and we are all grateful for your early interventions for some of our youngest members of the community, and you saved them years of ocular disease. So we're going to start with one very common topic. Is there anything I missed that you want to add about your
No, this
background
is
or your
perfect.
passion?
Yeah.
Great. And she's here local. You can find the link to her center. Um, can you tell us what's the best way for people to find you?
So our website is Children's Eye Center of Orange County, and we are located in Lake Forest, Orange County, um, here to serve our community. So,
Got that, wrote that in. So we're going to talk about the lazy eye, amblyopia. Why don't you let us know what is this? What can parents do if they notice it, and what are they looking for? And why do they
absolutely.
need it?
So, basically, lazy eye is one of the most common reasons why I see patients in my office. That's when one eye is a little bit stronger and sees better than the other eye. For example, one eye is 20/20, and the left eye, for example, is 20/60. So it's not seeing as well as the right eye. Lazy eye, about 5% of the population actually have lazy eye. So it's very common and it can happen in children. Um, Either the parents notice that the kids are not seeing so well, or they go to pediatrician's office and they have a failed eye exam where they can not read the chart as clearly. So that's the main reason why we get them.
Can you explain what would 2060 mean? People ask that all the time in the office.
Sure. So 20/20 means that at 20 feet, a normal eye would be able to see a certain size image. Someone who has 20/60 vision sees the same size image. I cannot see the same size image that a healthy eye can see at 6 feet, 60 feet away. They can see it at 20 feet away. So it's reduced vision compared to the normal eye.
Great, thank you.
So back to the amblyopia, there are different type of amblyopias that we can talk about. There are refractive amblyopia, and refractive amblyopia means that the kid probably needs glasses. And either there is a asymmetry between the two vision. One eye is needs more prescription glasses than the other eye, or both eyes need prescription glasses. And the young brain, what it does, kind of favors the eye that is easier to see and ignore the eye that is not as harder to see. And that develops the lazy eye or amblyopia. For the refractive type of amblyopia, usually we give them prescription glasses, and that's the first step that we do. Sometimes glasses alone will take care of it. However, there are cases that you give them prescription glasses, but you still need to do patch treatment in order to increase the vision in the eye that is a little weaker. There are other type of amblyopia as well. There's a strabismic amblyopia, or basically it's amblyopia where the eyes are either crossed or drifted out. And the eye that is not aligned, the vision can go down on that eye. And they develop lazy eye in that eye. For those type of strabismic amblyopia, we can give them glasses as well as sometimes patching, and sometimes depending on what type of strabismus it is, we may consider doing surgical correction. The last type of amblyopia would be more of a structural amblyopia, meaning that the kid has either cataract or a corneal scar, or they have ptosis that it led into favoring the eye that doesn't have those problems. And the eye that is a little has the corneal scars or cataract, the vision can go down on that eye. Again, same treatment. Either we do it surgically. If it is a cataract, we remove the cataract, and then we give them glasses. And then if they need to, then we can help them with patching treatment.
So, in summary, strabismus means that one eye is overcompensating for an eye that isn't seeing well, and then the brain stops taking the nerve stimuli from the bad eye. Correct? So this is the overarching theme for these three different types.
Exactly. So amblyopia or lazy eye is when, yes, one eye overtakes compared to the other eye, and the nerves that develops from the brain to the eye doesn't develop correctly in the weaker eye. So we like to give them whatever they need, be it glasses, patching, to kind of stimulate the brain to use the weaker eye and rebuild those nerves going to the eye. There is a time limit, however,
Yes.
how far we can really treat amblyopia. So it is important to catch the kids early and bring them in and treat them early, because they have better success rate. And there's so much time that you have before age of 9, 10, that you can regain that vision. After that, it becomes a little harder, and the brain is kind of set and the vision is kind of set. So early intervention, again, as you mentioned earlier, is pretty important in kids.
Well, what's the earliest age you find people bringing in their child for an eye that's wandering? So we know it's quite normal up until 9 months for some children. What would you
Right.
say?
So generally, I see babies as early as birth, but generally, talking about cross-eyed drifting eyes, sometimes it's normal to have cross eyes or drifting eyes before age of 3 months. However, after 3 or 4 months, that's the time that I would highly recommend for you to be seen by a pediatric ophthalmologist, because that's when we need to kind of figure out what's the reason for crossing or drifting and treat it appropriately at that point.
When you see them after that age, before one, is there a percent that will spontaneously resolve, or most of them needing an intervention?
So if before age of 3 to 4 months, they do spontaneously resolve. However, after age of 3 or 4 months, generally we have to monitor and treat. There are different type of strabismus. I know that's our next topic that we were going to talk about, but congenital esotropia or crossed eyes, for example, is something that the baby is born with the crossed eyes. And when they have a crossed eye and they come in to our office a little earlier, the treatment can be done earlier and their success rate is better. So that's why, early intervention, early referral to the pediatric ophthalmologist becomes very important.
This is all very common to see. So the question I have for you is, if a baby's cross-eyed has congenital esotropia, are they intermittently cross-eyed, or are we talking about it's majority of the time they're cross-eyed that you want to see a newborn?
So generally, it can go both ways. There are intermittent forms and there is a constant form. The congenital esotropias usually are constant and they're born and one eye is misaligned and it's not straight and the other eye may be straight. But they are intermittent form of esotropias as well. And for those, they need to be seen as well because sometimes they need as simple as wearing glasses that would correct the crossing. Talking about crossing, it's pretty important to have straight eye for developmental aspect of it for two major reasons. One is amblyopia that we already talked about, which is the lazy eye, because anytime that your eye isn't straight, your brain can shut down the vision in the eye that is not straight and the vision can go down. So in order to develop and have a good vision, we need straight eye. That's one reason. The second reason is depth perception. Anytime that your eye isn't straight, you don't have depth perception. And that's pretty important to have straight eye at young age because that's when you're actually developing your depth perception. If you let it go, and let's say you get much, much older and you had a congenital esotropia, besides the fact that you can have a decreased vision in the crossed eye, even if you treat it down the road, you may not be able to regain the depth perception. So again, timing is pretty crucial in kids and being evaluated early on.
Great. So I think that the take home is that if you do see this any wandering, you're never wrong to go and see a pediatric ophthalmologist. Very much better
Absolutely.
safe than sorry.
Absolutely. So talking about misalignment of the eyes, as you mentioned, we have the crossed eyes, which is the esotropia. But you could also have a wandering of the eyes, which is exotropia, as well as having eyes drifting up or down, which are hypo or hypertropias. And all of these can lead into a decrease of vision or not having the depth perception. Um, Esotropia is the crossed eyes. It could be simple as needing glasses, refractive type of esotropias, which we always give them glasses first and see how they do. Sometimes glasses alone will take care of the problem, but sometimes the crossing improves but not completely resolves, which then we call it mixed mechanism esotropia. And depending on the visual acuity, again, patching might be an option. And if it doesn't resolve despite of glasses and patching and medical treatment, then those are the patients that we consider surgical correction for the eyes at that point. Those are two types of esotropias. There are other types such as sensory esotropias, meaning, again, a kid who has, for example, cataract or a corneal laceration with a scar, the vision is not very good in that eye that was affected, and that can lead into crossing of the eyes as well. And the last one is also acute type of esotropias, where you can have neurological issues such as sixth nerve palsy that can lead into esotropias. If you do have an acute type of issue or if a new onset of esotropias, older kids can complain of double vision, and as well as adults will complain of double vision. But the younger kids may not complain of double vision because they kind of ignore the second image, and that's how their vision goes down and decreases over time. So if your kid or child complains of seeing two, or not being don't have a good balance and they don't have a good depth perception, it's a good idea to have them be checked for sure to make sure that they don't have one of the type of strabismus that you typically see in kids.
So, question about this: the older children who start seeing double vision, does that mean that at any time strabismus can come? It doesn't have to be something they're born with, but of course, cataracts can come later in life, and then that could be a reason for strabismus for an older child.
Yeah, absolutely. So there could be different reasons and different ages. The congenital ones, obviously, it's the ones that you see in the babies.
Mhm.
But even at the age of 2, you could see refractive type of esotropias or crossed eyes, and later on, 4, 5, and on, you can see crossed eyes for different reasons. Um, Even cataracts, some of the babies can be born with cataracts, unfortunately, and that can be even a cause of the crossing at the newborn stage. But you're absolutely right; it can come in all different ages, and some adults may even develop. Crossing of the eyes, being it because of neurological issues, thyroid diseases, general diseases, or even trauma can cause some of these crossing or drifting of the eyes.
And then, when you have older children with the double vision, are there other symptoms, or is that one of the first things they'll describe?
Yeah, that's mainly one of the main reasons or things that they describe, or the parents notice that the eyes are not straight. I get a lot of patients coming in and say, I talk to my kid, but they're not looking at me, or they're not paying attention, or they notice that the eye is kind of wandering out. And with the exotropias or wandering out of the eyes, a lot of patients come in because parents notice that the eye is wanders goes out when they're daydreaming or they're tired or they're in a car ride and mom is looking back and sees the eye not being straight. So those are some of the things that parents see, and that's a good time to just go ahead and get the eyes checked.
I had a young patient who was watching TV like this.
Right.
Is that the
Yeah,
strabismus?
absolutely. It could be due to strabismus, or it could be just refractive error. Some of the stigmatism or needing glasses basically would cause the kids to do different things, such as turning head or frequent blinking, even. A lot of kids that have intermittent drifting of their eyes or intermittent exotropias, they blink a lot, or when they go in the sunlight, they close one eye. And those are some of the signs that something is up. We need to get it checked out to make sure that it's not any crossed eye, drifting eyes, or because of other reasons. I mean, medical issues in the eye that are doing that.
That's very helpful. I have had patients come in with new onset rapid blinking, so
Right,
I'll
right.
be
For
I'll be
sure.
checking in with them after this.
Yes.
Then what percent of these issues do you find have a family history? Because I always remind families that they need to think about their family history because it seems to be missed on my patients.
Right.
They don't realize that, oh, well, if you had this, this is something we need to look for in your child.
Oh, for sure. So it is common in kids whose parents or family member had some type of strabismus, and it doesn't have to be the exact same type of strabismus. So, for example, if mom had crossed eyes, their child could have drifting or wandering of the eyes. So it is more common. I always recommend that parents who have a family history bring in their kids maybe a little sooner for evaluation for strabismus, because there is a higher chance for those kids to require treatment for their strabismus or develop down the road strabismus.
You were talking about age ranges where intervention is going to be the most helpful, and you said something about the age 9, 10. Can you speak a little bit to the point of how the brain's ability to adapt, and then what happens when someone is 12 and starts to have the wandering eye, do you have a limited time to intervene to correct the brain patterning,
Sure.
or can you even 10 years later go back and try to fix it and get some results?
Absolutely. So for amblyopia treatment or the lazy eye, where your vision is low, there is a time limit up to age 10 or so. Although there are some studies that are showing maybe older kids can benefit from some treatment down the road. You're still working on that. But the best treatment is done when there are the patching treatment or glasses prior to age of 10. Um, so its early intervention is pretty important in those kids. For crossed eyes or drifting of the eyes, if they are constant, obviously the sooner intervention is more important. For example, congenital esotropias do better when there are babies, and we treat them and we actually do the surgery when there are babies. The eye adjusts better, the brain takes over better, the visual development is better. For the more intermittent type of esotropias, such as intermittent exotropias, where the eyes are wandering out, we have some time for that. We watch them, and when it becomes more frequent, that's when we intervene and treat them. Again, with glasses, patching, or surgical correction if we need to. But either way, the surgery can be done at any stage, at any age. The more congenital, the more constant ones, the sooner better. The ones that are more intermittent, we may have a little more time to do the surgical correction. But yes, a full, dilated exam where all of the medical issues can be ruled out, and the need for glasses can be ruled out, and then after that we kind of see if the patient needs surgical correction at that point or not, and we go with that.
Okay, good. Yeah. I think people need to be comfortable coming to see you knowing that you're not going to jump to surgery, because that
Yes,
tends to really scare parents, which understandably, but
of
there's lots
course.
of interventions before you get to that point. That's good to know. Well, why don't we move to our next topic, unless there's something else you want to add that we skipped over about
Hmm.
eye misalignment?
Yeah, but any other questions? We could move on to the next one.
This is a popular question about styes and
Sure.
having those lumps in the eyelid that sometimes just take forever to go away.
Right. So that's another one that we get very frequently in my office. So styes basically are really oil glands that are plugged up or closed up. And what it happens is it can get enlarged, and sometimes they can get inflamed or infected or even bled into. They can be as small as just a little dot, or they can get really large sometimes. And the way I say it to a lot of my patients, I say it's kind of like having acne. And, a lot of kids get them, and then, they grow out of them at some point. And the treatment for it is really doing warm compresses, because you can imagine it's a sack of oil that you're trying to melt it out, and you want it to just come out of the sack. So heat is the best treatment for the styes initially. So initial treatment is really just warm compresses. If they do get infected, sometimes we do give them antibiotics to help with that. And because there is some factor of inflammation involved, fish oil supplements are sometimes recommended that the kids can take, and that's a good preventive method of getting the styes, as well as washing the eyelashes on a daily basis. And I suggest making baby shampoo solutions or pre-made packages that they sell over the counter, and you just wash the eyelids and prevent those glands from closing up. They do reoccur, and they can happen in the same location of the eyelid, or they can happen in different location or a different side of the eye. So initial treatment is really the warm compress, and you would do that consistently for 3-4 weeks. And if it doesn't go away and it's really large, that's when we intervene and we can actually drain it. And with draining, obviously with kids, it's a little bit more complicated because they can't do it in the office, and it's more of a surgical thing we do. So it's a last resort. Um, but it does help to just drain it a little quicker. And then the other option, if there's some part of scarring involved, sometimes we can do steroid injections into the styes, and it helps to shrink it a little bit better over time.
Super helpful information. I have patients going back again and again after 6 to 9 months. So, and I've told them to come see you because there has to be something more that you can do. It does take a long time though, and I guess as a pediatrician, you hear all the different tricks. The tea bag,
Right.
the boiled egg. I think the easiest when my son had one was just a warm washcloth that you could keep dipping in the water and let
That's
them
right.
watch TV. Yeah.
So any way you can apply the heat is the best way to do it. You just want to just drain it sooner than later. And it's easier when they're smaller and you can drain it that way rather than when they get really large. And then at that point is when we go and drain it and help it to drain out a little bit better.
I know, and getting it early, like you said, having
Yeah,
the experience of seeing children deal with it for months, I just get my son on that couch and say, "I see something. We're gonna
that's
do this."
right.
But yeah, some families are prone to them. You can find that they just have that type of skin.
Of course, yeah.
So yeah, glad that you spoke about styes. It's a simple but very common problem. We'll
Of
go to
course.
our last topic for our little babies, the blocked tear duct, which
Sure.
manifests in so many different mild to severe cases. So I'm so glad you wanted to speak about that.
Sure,
Go ahead.
sure. So, that's also another common problem that a lot of newborns come into my office with a lot of tearing or discharge. Generally, the blocked tear duct is when in the pathway of the eyelid going to the nose, in the pathway, some part of it is closed, and typically is the valve on the distal part of the nasolacrimal duct, the valve of Hasner that never opened up after birth. And so the drainage or the tearing will back up, and it will sorry, the light went off. And it backs up, and the patient ends up having a lot of tearing and discharge. Um, Usually, for that one, a majority of them do actually resolve by the age of 3 months, and the rest of it can resolve before age of 1 year. So a lot of times when the patient comes in, I show them how to do a massage where they can help it manually to pop open the valve by doing the massage between the nose and the tear duct area, putting a good pressure on that area. And releasing it every time they're doing a diaper change, they can do that. And it helps to pop open the valve. Um, if it doesn't pop open by the age of 1, that's when we recommend a surgical correction or opening. Again, the reason why we do it is because the possibility for it to spontaneously resolve is not very common after age of 1. And also, as you can imagine, a lot of tearing and discharge can cause irritation in the eye and frequent infections in the eye. And so we want to prevent the infection and irritation. And we, again, do it a little sooner than later because we want to make sure that the kids don't have infection, as well as it's an easier procedure when you do it when they are younger and it hasn't hardened up yet. And you can open that valve easily.
Great. And there are so many YouTubes, and everyone's bragging that there's a specific way you have to hit that duct. And is that true? If you're just doing a good amount of pressure right in here,
Right.
and I'll
So
show them
the
how to do
way
it.
I recommend is really getting your thumb and putting it between the nose and the eye and putting a good pressure and pressing about counting up to five, 1, 2, 3, 4, 5, and then letting it go. And then if you do that 2 or 3 times, every time that you're doing a diaper change, you put in a good enough of a pressure that that pressure may pop open the valve and help, avoid a surgical correction down the road, hopefully for the baby.
I like to recommend with the feeds because you get a very fussy child with diaper changes anyhow. But if
That's true.
they're getting their milk, they're pacified, and they'll let you do anything.
That's right.
Yeah.
That's very true. That's
Yeah.
very true.
Keep the struggles to a minimum.
Yes,
Great. I'm trying to think if I have other questions about blocked tear ducts, but I do not, and I don't see any questions in our comment section. So that's a great help. I'm so glad you're local and that you make time for it. She will fit anybody who has anything urgent. She'll fit you in. And
absolutely. My pleasure. Thank you for
we
having me. I really appreciate it.
thanks for being here. You guys can find her at the Children's Eye Center in Lake Forest. And I will post more on that after we close the talk. Have a great Friday. Have a great Halloween. Thank you for being here.
Thank you. Have a